Dr. Spencer Nadolski, a family medicine resident, and I'm here with my brother. You can introduce yourself.
Dr. Carl Nadolski, board certified in internal medicine and obesity medicine.
And we're basically here to talk about something controversial that we see in the blogosphere, all about cholesterol and statins and things like that. I'm going to kind of come at it from a primary care standpoint, and
I'll try to take it from also a primary care standpoint, but also from trying to specialize in obesity, metabolic syndrome, and we've both been really interested in helping people decrease their cardiovascular risk ever since we've been in medical school, interested in lipids, lipidology, which is the cholesterol that you hear about that we're going to talk about.
So I guess we should start off with, like, what actually is the controversy here? You know, there are a lot of people that are just against big pharma, statins, and against what is called the lipid hypothesis. Can you kind of explain basically what the lipid hypothesis is? I mean, basically, high cholesterol causes.
Yeah, basically what most patients hear about, they hear about their high cholesterol, whatever that means. Cholesterol itself is really just a steroid hormone that is used throughout the body and we need. But what we're actually talking about are lipoproteins that carry the cholesterol hormone throughout the body. And over many, many years of research trying to figure out what's causing heart attacks and coronary artery disease, the early studies we found out were correlated to certain risk factors, which many of us know. Obesity, diabetes, high blood pressure, but also
smoking.
Smoking may be most important. But also it turned out that as total cholesterol went up, so did mortality from cardiovascular disease. There are some caveats to that we'll get into. This was repeated in multiple different studies, from the Framingham to Mr. Fit to what else?
I don't know. It's been in so many different studies, but the controversy is that a lot of people on the internet, and you know, there's people really into that aren't doctors, that are really into their own health, are studying up on this and kind of checking out what the doctors are saying, and basically they're getting mad because apparently certain doctors, just by checking a total cholesterol, were putting people on statins based on the old information. Statins are, you know, for you lay people out there, statins, it's an HMG-CoA reductase, which basically stops the production, the downline production of cholesterol.
And we've had other medications previously that also altered how much cholesterol you had and the different ratios. But then as we became more advanced and we learned about the different types of cholesterol proteins, the low density lipoprotein, which you hear about as the bad cholesterol, and the HDL, the high density lipoproteins, which is the good cholesterol, and then you hear about triglycerides, which are the fatty molecules that actually make up, that form some of the fatty cores of these lipoproteins along with the cholesterol. And the further studies of the Framingham Offspring study and the Lipid Research Council and etc., along with knowing about familial hypercholesterolemia, genetic traits, show that LDL was a little bit better at showing correlation with heart disease as it went up, and also HDL, and that's actually one of the other risk factors. When you have low HDL, it's associated with a higher risk. And then as we've gone on with studies like MESA and EPIC Norfolk, the Stanford 5 Physician Health Study, etc., we've now learned even more about these lipoproteins, that LDL isn't necessarily always bad, but sometimes we have more particles and less particles. It's about particle number, not necessarily just the cholesterol that's in LDLs. And then the HDL gets even more complicated as we're starting to learn maybe raising HDL with different medications isn't exactly what we have to do because they function differently, different particle numbers, etc. there. So it's getting complicated, but there are some ways we can simplify it and maybe get to the bottom of the controversy and figure out why everyone's all been out of shape on the internet.
Right. So hopefully we don't get too complicated here, but it's hard not to dive into it. So the people on the internet might have some good reason to get a little peeved because, you know, if doctors are giving a statin to just decrease your total cholesterol, that's probably not the whole story here. As my brother talked about, these actual lipoproteins are what we should be looking at. And, you know,
and overall risk.
And overall
because
risk.
Everyone has different risk factors, and,
right.
and, you know, we try to push a holistic approach And that's obviously what we try to do specifically.
So basically, I want to go through if some patient come into me, into my clinic, or on the internet. I get a lot of people asking me about their lipids on the internet. They say their doctor wanted to start them on a statin because of their total cholesterol. I'd say, well, okay, well, break it down for me. And they say, whatever, their total cholesterol was 216, 220, and their LDL was 120, 130s. And their HDL was like 55, and their triglycerides were like 70. I'm sitting there going, okay, well, what other risk factors do you have? So there's something, when somebody doesn't have any risk factors, we look at a number of LDL that you have and non-HDL and all these other things, and we also look at it when you have other risk factors, such as smoking, blood pressure, and diabetes. So you really, the people on the internet don't have very many risk factors. So I guess
generally speaking,
unless they just have this high LDL, which
right, that can be a little bit more complicated too. But it's if you have high LDL, really high LDL, that's something that needs to be discussed and somehow addressed.
And I guess we're kind of getting into this convolution here, but the people on the internet, blogosphere, and even this new book that I want to kind of review, made by Dr. Johnny Bowden and Dr. Sinatra, talk about basically the statin scam, how the cholesterol myth, and that these things maybe aren't as big of a risk factor, which we don't disagree with, but what's the bottom line of what's actually causing this atherosclerosis here? So basically, all right, so in the book, their excuse for cholesterol not being a risk factor is that they go over a couple different things. Based on, doctors think that, in the internet, doctors think that cholesterol is the end-all be-all for risk reduction. That's why we want to give statins to everybody. But in the book, they talk about a few different things. There's the Lion Diet study. Lion Diet study showed that just changing some of your things in your diet actually reduced your cardiovascular risk. So in the study, they basically put a certain population, one of the groups, on a Mediterranean diet, higher fruits and vegetables, but also breads and more monounsaturated type fats, and also decreasing your red meat.
And nuts and legumes.
Nuts and legumes, and also decreasing your pork and putting them on chicken as opposed to pork. And what their argument in the book, in Dr. Bowden's book, is that, well, these people on this diet decreased their risk of cardiovascular disease, but their cholesterol didn't change. So cholesterol can't have anything to do with it. Another thing that they pointed out was there's something called, there are two different drugs. So we keep talking about statins, but there's another drug called ezetimibe, which decreases your cholesterol through different mechanisms. So they put them together, and they figured the lower your cholesterol, the better, because that's what, that's the whole lipid hypothesis. Well, the surrogate marker they were looking at was something called CIMT, carotid intimal media thickness. It's where they're looking at ultrasound right here in your carotid artery to see how much, how thick it is. And before they thought it correlated well with coronary risk and things like that, but it's not. It's not.
To some degree, it does, but it's still a surrogate marker.
So anyway, in this trial, they basically showed that the people with these combo drug, they lowered the cholesterol more, but it didn't really change the outcome of the CIMT. So they're basing a lot of their book on that one trial, but really what we should be looking at is the hard end point of cardiovascular mortality and mortality.
Heart attacks, strokes,
so
and death.
Having said that, I know I keep blathering on, but there's a new trial that should be coming out called the Improve It trial that's going to actually look at those cardiovascular outcomes, and we'll know by the end of this year. So I just keep bringing these things up to kind of play devil's advocate that, I know these books are saying cholesterol is not a big deal, but I don't think we know exactly everything yet, especially with all these new tests coming out. Another thing they brought up was the Nurses' Health study that basically showed all these different risk factors that correlated to death, cardiovascular death, and cholesterol wasn't one of them. It was BMI, smoking, and I think fruits and vegetable intake.
And women are a little bit different, and the studies all show that. However, there are some things that can tie it all together.
Another thing that that the book pointed out was that the pattern of the LDL mattered more. So a pattern A. So when we talked about, you know, you got your good and your bad cholesterol, the HDL and LDL, but what we really are talking about is those lipoproteins that carry the cholesterol. And the pathogenesis, you know, how you get this atherosclerosis, the plaque in your arteries, is the idea that these small little LDL particles, the smaller they are, the more readily they will get oxidized and actually penetrate your endothelium, the inside of your inside of your blood vessels, and basically eventually cause inflammation and plaque buildup. So what they're talking about in the book is that it's the size that matters most. So they say big fluffy LDL particles will not penetrate, and it's basically harmless. And they say that that's a pattern A, which is what you look when you get these specialized tests. You'll say pattern A or pattern B. So they say the only thing that matters is the size. So if a pattern B, if you have a pattern B, you should be worried. If you have a pattern A, no matter how much cholesterol you have, you shouldn't be worried. Well, as we're coming to find out, one of my critiques of this book was that since you can now check how many particles you have, they're actually finding it's the actual particle number, not just the size, that matters a lot. That's one of the things that if they updated the book, they'll probably come out with that. But I guess one of the things I just really liked about the book is that the underlying pathogenesis, the cause of this coronary disease, cardiovascular disease, is likely oxidation inflammation.
Yeah, but it does involve these lipoproteins that we're discussing. Right. So when they say it has nothing to do with it, that's not true. We all do need cholesterol, and we do need the lipoproteins that carry them, but we need to keep the lipoproteins we have healthy, and it would be nice to keep our LDL low. It's even better to keep our LDL particle number low, as it's turning out in these advanced lipid particle testing with lots and lots and lots of different studies. And there are different ways we can do that. And all the things that we talk about and promote, trying to defeat metabolic syndrome, that's where the belly fat is causing all sorts of havoc on your muscle's ability to use insulin. That's insulin resistance. The high blood pressure, which is obviously a high risk factor for heart disease. And then it's actually that metabolic syndrome that causes some of these differences in your LDLs and HDLs. The low HDL-C, the high triglycerides, but then that just shows us kind of the window into the particle risk. The LDL particles being low is usually associated with lean, fit, healthy eating, exercising individuals, whereas the opposite is associated with the metabolic syndrome. And even though LDL-C does correlate with cardiovascular disease, when it is what they call discordant from that LDL particle number, the LDL particle number is much better at correlating. And that could get us into the CRP and some of these other primary prevention studies where there's a lot of debate about using statins, because that's the other thing. These guys all hate statin drugs, and
yeah, the blogosphere is what we're talking about. I guess we just kind of want to try to clear it up. Coming from a doctor standpoint, coming from he's going to be an endocrinologist fellow. I'm coming at it from a family practice, a general practitioner. I think there's a dichotomy that our general population that we see in the clinic is much different than the folks on the internet, and we argue with these people and play devil's advocate on Facebook, but we're talking about two different people,
right? And yet we're all in the same team.
We're all in the same team. We should all be a team. In fact, the people on the internet, the naturopathic doctors, even acupuncturists, whatever you want, we should all be in the same team. We shouldn't be against each other. I guess the bottom line is, so if I had somebody in my clinic, like we just go over this again.
Like if I were your patient.
If he was my patient and he didn't have any risk factor, which he doesn't smoke, he's got negative 3% body fat, and
exercise, good family history,
and his LDL-C were a little bit high, the LDL cholesterol.
It's not, but we're pretending. I don't know what it is right now.
Yeah,
it's okay.
So what would I do? I'd say, okay, well, it's a little bit high. It's the ATP. We have these guidelines that say if it's over 160,
based on evidence,
you have somewhat of it's a risk factor.
What can we do about it?
Okay, so what we do, actually what I would do is I'd probably retest you in a few months. Maybe not if he already has good lifestyle right now, I'd probably retest it. Mm-hmm. The other option is if he's really into his health, like there's a lot of these people on the internet, we could get a particle number.
Mm-hmm. What about CRP? Would we get that in me? Based on recommendations? Probably
based on recommendations. The reason we wouldn't is it's shown it doesn't really add much to the LDL.
To a very low risk person. To someone who, like if I did have a family history, or if we weren't really sure, maybe I have a little blood pressure, then suddenly it becomes a pretty good thing, and there's a different risk calculator for that too.
Right.
And that's a little bit better. But
now, however, if I got somebody in my clinic that's just your run-of-the-mill 50-year-old guy, run-of-the-mill 50-year-old guy that comes into my clinic, just coming in for a screening, he's got a little bit of visceral fat, based on my waist circumference, he's got has that metabolic syndrome picture, has insulin resistance, may or may not smoke. The number one thing is, no matter what, I'm going to do lifestyle recommendations. Yep. I'm going to do lifestyle recommendations regardless of what his lipid panel looks like.
Absolutely.
Now, the problem is if his LDL comes back and it's a little bit high, I'd still retest it, because what you find is that there's a certain standard deviation of how these tests are going to show.
They change.
So you can test it in a couple of weeks, and it might change by 20 points, and it's calculated. That's the other thing with the LDL-C, based on
that could bring us to talking about non-HDL and actually looking at the pattern a little bit more. Doing a non-HDL where you just look at all the proteins other than HDL gives you another, I call it a poor man's version of doing an advanced lipid protein testing, and it's better than LDL also, and is pretty close to looking at ApoB and LDL particles, which are advanced and a little out of the realm of this conversation.
But anyway, so if I had a guy that was at risk, had a little bit higher blood pressure, and his cholesterol was a little bit high, and he wasn't going to do lifestyle changes. I knew he wasn't going to do lifestyle changes, because you can tell the patient, they're not on the internet looking up everything. They've had high cholesterol for all their life. I might consider putting the guy on a statin.
Yeah,
there is good evidence that you can decrease cardiovascular mortality, and what we're calling prevent the first heart attack, primary prevention. It's very small, but it's in that higher risk population.
Right. The more risk you have, the more benefit you get.
In someone like my brother, primary prevention, it's not going to help much, and in fact, the statin might harm. So that's where we get into this dichotomy. Right. You people on the internet, you're so into your health, you're so into paleo diet, whole food, low inflammatory type good foods, that the statin probably wouldn't help that much. It might lower your cholesterol, but
and maybe long term, if you're preventing plaque buildup over the long term, that's where there's controversy in the medical research realm. We don't really know the risk-benefit ratio of a statin in a low-risk person who hopefully is not building up plaque. But someone, like he said, a 50-year-old who maybe had been building plaque for 50 years, the minute he started eating stuff that wasn't good and not exercising, then you have to start looking at other risk factors and how much benefit are you going to get from one of those statin medications or one of the other medications that have been shown to be beneficial before we had statins. But the statins are the ones that have the extra benefit of possibly lowering inflammation, the CRP stuff, the pleiotropic effects that we talk about of statins. But they do have some risks, and we try to combat those. I would like to put a plug out there for doctors. There are multiple different statins, and if you really are aware that different ones have different metabolism to be able to combine with different medications, etc., and of course doing all the lifestyle things and trying to minimize the adverse issues with some of these medications, they are beneficial for a lot of people.
Right.
But we don't take them because we don't need them. We have no risk factors, no reason to take them. The benefit would probably be negligible at this point until further research comes out.
And which is like most of the blogosphere out there. I mean, there are some that what we were talking about earlier, not on video, but maybe a 50-year-old that just says, "Oh, I'm going to make those lifestyle changes." I would be personally hesitant to put them on a statin if they're really going to go gung-ho.
Especially if they're going to start lifting hard and really working their muscles, because that's one of the things that the muscle aches, but I mean, then we can get into coenzyme Q10 and stuff like that, but
right.
that's again out of this.
So, okay, so going back to my brother as like my patient, if his LDL-C were still high, and when I say high, above 160,
yeah.
I keep retesting, and I got an LDL particle number, and it was still, and that was high. There are a couple things we do. I would check, I would screen for thyroid problems, because that's one of the known things. If you're thyroid, if you're hypothyroid, your metabolism's low, so your clearance of your LDL is.
Now you didn't really mention what my total and HDL were, because you would calculate it on HDL first.
Right, and I could right.
Yeah, I mean,
right, and that's true.
Hopefully, but hopefully my HDL is pretty high.
But I'm just saying. So if we did look at your particle number, just basically look directly at the particle number,
yeah,
that was high.
That would be something. Maybe
I would definitely screen for the thyroid, and I'd also make sure nobody in his family has familial hypercholesterolemia, because that,
or even just a predisposition to heart disease. I mean, that'd be.
And so.
But then what are we going to do about it?
Right. What are we going to do? So if it is high, and he doesn't have those, it's not hypothyroid, he doesn't have familial hypercholesterolemia, we probably go through very specific lifestyle things, such as, I know everybody likes the saturated fats on the internet. I know you guys love it, but there are certain people that are sensitive. I've seen it in the clinic. I've seen it on the internet.
And the evidence is there.
The evidence is there that it will, and it will increase your LDL. And so. And does it matter?
It does increase HDL, so a lot of times the pattern can still be very good. You can have a very good non-HDL that kind of correlates with your LDL, even though the LDL is kind of high, but overall the pattern is pretty good.
So the question is it really going to matter though? I honestly, it hasn't been studied in people like us that have no other risk factors, and they don't follow people like us on these studies. Yeah. These are like general population type of people. Yeah. So,
and this can springboard to our next conversation about dietary changes for reducing your cardiovascular risk. But generally speaking, we try to promote getting a good balance of natural sources of fat, and maybe most important, increasing your vegetables, lots of fiber. We know that's good, and that works in a different mechanism.
So yeah, so let's go over what is the bottom line here. The people on the internet, you're young. You might have slightly higher LDL than what we would like, and then your particle numbers, and you get a particle number because you're so into it, and it's maybe just slightly a little bit higher than your risk, with no risks. I don't know. I wouldn't start you on a statin. I don't generally start people.
Not initially.
I don't start many people for primary prevention of statins just for a little bit of high LDL. Mm-hmm. But when somebody has diabetes, full-blown diabetes, not just maybe we are a little bit different.
Or even metabolic syndrome people, that maybe pre-diabetes and high blood pressure.
If I know somebody
low HDL.
Bottom line, if somebody's going to go, balls to the wall with lifestyle changes,
let
completely.
Them do it first.
Let's do it. Why put them on a statin?
Yeah, help your patients do as much as they can first, and then try to optimize the risk-benefit ratio. And there are other drugs. We have bile acid sequestrants, niacin, the Zetia, but lifestyle stuff should always be first. And even though most people on the internet are kind of knocking doctors down for not doing lifestyle first, I promise you they should be, and hopefully most of them are. The patient population isn't like what a lot of you guys watching this video are.
Right. And that's kind of our ending point, is that they think it's the doctors basically pushing this stuff, but what happens is that the doctors have been fed up, and people don't follow what they say,
but they'll take a medicine.
People do want a pill. It's hard for me sometimes.
Not everybody.
It's hard for me in the clinic sometimes, because about 8 out of 10 people, maybe 7 out of 10, 8 out of 10 mostly, would rather take a pill than do what I say. And I've been training myself and practicing motivational interviewing and these types of things, so it's still a very low percentage. So people put the blame on us, but the patients don't really like to, so don't like to go through this lifestyle changes, and so they'd rather take a statin.
But not all of them. There are plenty of them, and like you said, the 7 out of 10 might want the pill. That leaves a certain amount of people. I have plenty of patients who, when I really start talking about lifestyle and trying to get them off of their medications, they get really excited, and some of them are so motivated that they do. I've gotten people off of insulin, some people get off of their statins, maybe they still need some other stuff to really reduce the risk because they've already built up some of that risk over the years. But you know, based on evidence and calculations and risk sort of expectations, we do what we can to try to help people optimize their cardiovascular risk, hopefully through lifestyle, but we'll do what we have to do to help people.
So basically, we agree with you.
Bottom line,
it sounds like you guys think that we don't agree. Doctors don't agree with you and whatnot. We're all pretty much on the same line. Maybe Big Pharma probably doesn't agree because they want to make money. They want to give everybody statin and they want to put it in our drinking water. I understand that argument. We should all know
to be aware of it.
We all need to know the indications.
Yep.
It's great as internet patients. You guys are really into your health and you come in loaded with information. And I know we're big on doctors and patients having that coach-quarterback relationship as opposed to a dictator. Yep. Do it my way or the highway. So we think that's great. We're agreeing with you, and I think we all just need to work together better. Yep. Fitness professionals, alternative medicine practitioners. I'm just trying to learn. We want to know the truth. So that's all we got to say today. We probably went a little bit further into what we wanted to talk about,
but perhaps we can take questions. Find us on our website and on Facebook. Leave some questions, and maybe we'll have a follow-up video and answer some of your questions.
Definitely. Leave comments down there. You can go to our forum, ask questions on our. You can add me as a friend on my personal Facebook. I think I have a little bit room left to my 5,000 limit, and obviously on our Facebook page. So anyways, talk to you soon. Thanks.